Now we have nearly half an hour of time. I would like to invite our four speakers to sit down here and we can start the discussion. Christian, please, you are going to be surrounded with three surgeons. I dealing as a fourth surgeon, but I'm going to be your side. Okay, we can start with the question, please.
For the three surgeons, you're not fully agree on the period of physical therapy before doing a surgery. So on the one hand, it's 6 months. On the other hand, it's 4 weeks. Maybe we can start on the left side and give some opinion why you wait for 4 weeks, and then we end up on the other side, why you wait for 6 months.
For me, it's not more than 4 weeks. And if there are pain, recurrent pain after rehabilitation, but good rehabilitation, I think that if the lesions are very evident, I do operation.
So then even within 4 weeks. And okay.
Of course, that depends of the clinical examination and the ultrasound or MRI. If there is a clinical painful inguinal area with bulging and pain when coughing, I don't do physio. I propose surgical repair. If it's a professional athlete, usually he accepts. If it's a recreational athlete, only doesn't want to have surgery, I give him some physio to do. And some of them go well after 2 or 3 months. But in a professional athlete, I propose surgery, and usually they accept, even if they have not had 2, 3, or 4 weeks of physio.
It's my experience, 3 to 6 months is the average time, because 20% of these patients will become asymptomatic with physiotherapy. So we don't want to be operating on people who will get better by having physiotherapy. The 3 to 6 months has just been more or less just evolved over a period of time, but if we do have a very highly level professional trained athlete who is undergoing physiotherapy and we've been alerted that this player is coming at the end of the season, maybe 3, 4 months down the track, we won't wait, we'll just go straight to that player and do the surgery.
Other question, please?
Can I ask Christian Thorberg a question? What is your management for a patient? On the slide that you showed a complete adductor longus avulsion. What's your management for that patient?
Oh yes, the tendon injury where they pull up the adductor longus tendon. Yeah, that would I'll show that in the next talk. But that would be conservative treatment. So that would be again a training program based on strength and coordination. So actually very similar, starting off very similar as the overuse program, but then go into more sport-specific stuff, but also more strengthening, more aggressive strengthening than we've done previously.
And what's the period of incapacity after a completed adductor longus avulsion?
I'll show you in the next talk, because with the same guy getting injured first in one side and then coming back, and we thought he came back because he had a re-injury, but it turned out he had an injury on the other side. First time he took more than a year to get full strength. The second time he took 10 weeks to get full strength on the same injury when you looked at it on ultrasound. So my take on this would be that, again, you could have very different injuries, acute injuries, that will heal up very differently as well. So I think we have to be careful saying this kind of rehabilitation or this kind of surgery, because that's, if I were to sort of comment on that with the rehabilitation or not, what I'm thinking as a physiotherapist or somebody deals with these athletes, I'm not sure whether we're looking at, is it an overuse injury or is it an acute injury that you're repairing, or is it sometimes both? Or because if you're looking at an overuse problem, it makes sense that it doesn't just go away after 4 weeks. But if you look at an acute problem, you might have better results with the fix. I don't know. Does that make sense?
Yeah.
Yeah.
Could I ask Per Holmek a question also? Per, what's your view on reattachment of the adductor longus tendon to the pubic bone in the complete avulsion situation?
I was in New Zealand last year while there was a World Cup of rugby. And Dan Carter, one of the best players of the New Zealand side, tore off his adductor longus. And they sent him to Australia to get it refixed, reattached. And as far as I know, Australia is one of the countries that cut the most adductor tendons. So I thought it was quite a joke and a funny way to react to something like that. So in most cases, I think we can do without surgery. We don't have to do reattachments in these cases. I know that Childers, for instance, in the UK, who's also doing a hernia surgery, is an orthopedic surgeon, but he's a pupil of Martens from Belgium. He reattaches some of these avulsions, and you could do that. As with most of what we've been talking about today, there's not much level 1, 2, 3, maybe some 4 science to this. And I don't, I can't really advocate for doing one or the other. The few cases with total avulsions will, in most cases, just retract a little bit, will heal back, but they'll, in most cases, take a long time before they are equally good to the other side. On the other hand, the patients we see who had adductor tenotomies during surgery are giving us quite a few problems, and some of the numbers that we've seen from some of the papers with only 2, 3, 4, 5% failures and 97% success, well, all these failures, they end up in my office, and I guess they end up in other offices as well. So maybe the figures are, I think a lot of this is reflecting that nothing really ruins good results as proper follow-up.
Could I ask the question? The question is for the surgeons. How many of you believe that after showing this lady who have the biggest series for the moment, who is still active, that the player can start the training 7 days after surgery?
Impossible.
Impossible.
I think that 1 week after they can run slowly, and you can say it's return to sport. But when she says they go back to sport on 8 days, when she published her results in 2010, it was not 8 days. It was, I remember, 16 or 17 days. So it's one thing you tell and another thing you write. So I think you must wait for the healing of what you have done, because the healing process takes time, and it's not. If you put a mesh, there is quite no healing process. But she is doing down suture, so there is a time of process. But what is important that she says, the athletes will begin very soon at 8 days to run, and that I think it's very important. But you run slowly, progressively.
Let me, third question, third surgeon, please. Could you give us?
I think that for Madame Mouchevec, it's 8 days, and it's not possible.
Okay. Next question. How many? Can I finish? Only. Next question for the surgeon. How many of you believe that after surgery done to these sportsmen, most often football players, you reach 96 to 98 excellent results. Dr. Garvey, what do you think? Is it possible?
Mine is a work in progress, and I would estimate that I have about 90% success rate in sports people, but in injured workers it's more like 70%. But my work is still evolving as far as searching out follow-up.
Dr. Picard.
I think that when we read and when we walk, maybe everyone has between 90 and 95% rate success. And I just want to say one thing with Mrs. Mushavek. There is no tension between conjoint tendon and ilioinguinal, so there is no pain in our patients. That's why the patient can go back on the field sooner than if they have shoulder repair. If you put a mesh, there is no tension, so they can also go faster on the field. But the criteria is a return.
Could you reach 96% results? That was my question. Could you reach 96% results with in your patient after your surgery? That's the simple question. Yes, no.
Yes.
Okay. Next question. Direct response. Could you reach 96 to 98%?
About 90%. But the problem is what the good results. Well, the good results.
The question is simple. Do you?
Yes, I understand.
Okay. Can I ask because all these people who are listening, they see lots of these operated patients, and how many of you that you see this operating patient, they reach 98% excellent results, or they are still after surgery complaining of some amount of pain and you do the physiotherapy and so on? Who is 98% and there is no problem after surgery? Could you get up your... no one. That is very interesting things when we are talking about surgery and presenting results in the literature. The first guy, Dr. Garvey, who showed us, Neshovic, and I knew him also personally, he had 100% excellent results. And next, in the big name that we had, that's Dr. Gilmore. He have 98%. And now we are in 2012, and we are still in the beginning. And that's excellent that we are going to have this Groin Pain project, that we are going to put all these people together. And once again, thank you very much. Is there other question?
Why are you performing a neurotomy and not neurolese? If there is a weakness of the wall, you repair the weakness. Why you touch the nerve? If the pain is coming from the nerve, you can perform the surgery on the nerve and not on the wall. But why you are performing the neurotomy, please?
The obturator neurotomy is performed because obturator nerve entrapment is part of the groin injury syndrome, and a percentage of patients will have this pain radiating down the medial aspect of the thigh and hypersensitivity to pinprick sensation. And initially I used to do the EMG to confirm obturator neuropathy. It became painful and expensive, so now I just do the ordinary pinprick test, and the outcome of that is extremely good. On the few that I have done post-operative EMGs, it's been normal. So the reason for releasing the nerve is because it gets trapped up in the inflammation of the fascia around or underneath the adductor longus.
It means that there is two real problems, two anatomical problems.
What is
The
that?
entrapment of the nerve,
Yeah.
and there is the weakness of the wall.
Yeah.
There
Yeah.
is two things that you are performing.
Yeah. But it's all part of the one syndrome.
Yeah.
But, John, it was not only the obturator nerve, there's lots of other nerves that you're cutting.
Yeah.
Yeah, so it was these nerves the question was about, I think.
Yes, I think the other part of the answer is when you do Schuldeis or Muschavec repair on fascia transversalis, before you do the down suture, you must cut the funicular vessels. And the funicular vessels, in 4 times about 10, I think, you have the genitofemoral nerve with it. So on local anesthesia, when you put a clamp, patient say, ah, yeah, because and this nerve is very deep. So if he has pain after that, it's very difficult to find it. And I think that's why Mrs. Muschavec and a lot of other people, when we see the nerve, we cut it and we put it inside the abdomen. So there is no nevroma, there is no pain after that. The ilioinguinal nerve, we preserve it. If there is pain, it's easy to find it. Ilioinguinal is also easy to do it. And there is no adverse effects of cutting the nerves. There is on hernia surgery a lot of randomized controlled trial, I cut, I don't cut, and there is no problems cutting them. So I think it's we can cut it if we see this nerve.
We don't identify the genitofemoral nerve specifically. We leave it alone and we don't cut any nerve. We just try and preserve what's there, unless it's obviously entrapped in a previous mesh or in scar tissue. We will resect the nerve according to the Ahmed technique, but ordinarily we don't cut nerves.
Other question? Oh, sorry.
I just want to ask about irradiating pain from low back lumbar spine. Is it something that exists in your experience? I'm asking the question to Christian. And what will change in your management of your patient if it's the case?
Could you just repeat the question?
Irradiating pain from lumbar spine, is it something that you...
Yeah, it's in the assessment, yes. It's very rare that we see athletic people coming in with a problem that we can reproduce in the groin. But yes, it's something that we examine as well. So if that's the problem, then they're not a real groin patient. Does that answer your question?
What will change in your assessment, in your treatment, I mean? This is...
No, in the assessment, we assess for that as well, yeah. To see whether that's part of the clinical picture, but it's very rare we see those things. I mean, and Pierre can probably tell that more than that, but 20 years ago, we were told that everything was coming from the spine. All these problems were not soft tissue problems that could be fixed by exercise or even surgery. They were things that had to be treated from the spine. But we must say that it's very rare that we see that in our examination anyway.
We seldom would examine for low back pain, although it is described as part of the syndrome by Moshevec and by David Scott from Liverpool. But we seldom if ever see that. Do you see it? It's part of the groin injury syndrome yourself? Yes, I agree with that about sacroiliac joint. I agree with that.
I have a question as well for the surgeons. If we should seek your advice on what kind of surgery we should use for the randomized control trial. Dr. Garvey has already alluded to us that there's lots of different surgeries out there. And what if we ended up with a fairly good result with the exercise treatment and a minor, medium result with surgery? And we used your type of surgery, for instance. wouldn't Payanen, Gilmore, Mushawik, all the others come and tell us, oh, it's just because you used Garvis, it's no good. You have to do this or this or this. Then it would have been much better. Do you think we could reach some sort of compromise? And would we really have to cut the adductor tendons?
Well, I think it doesn't really matter which form of surgery is used. It's just got to be agreed amongst the trial workers what they want to do. And if exercise therapy comes out very, very prominently, well, I think we've just got to accept that as part of a randomized controlled trial. That is the outcome. That's what we accept. I don't think the type of surgery. I think what we've got to decide is whether it's going to be open or whether it's going to be laparoscopic. I think they're the only two questions, because essentially all the open procedures have the same result.
Well, I don't agree. Because if we read all the RCT on hernia surgery, we know some obvious things. First, in open repair, Schuldeis repair is better than McVeigh, Bassini, or others. Second thing, if we compare open repair with laparoscopic repair, the recurrence rate is more important in laparoscopic surgery for hernia repair than in open repair. Second, if we want to compare Schuldeis repair between mesh repair. Mesh repair, Liechtenstein tension-free mesh, is very easy to do for the surgeon. It's a very good job for the industry, so it's à la mode. But it's quite Toronto Schuldeis Institute does not publish about pain after surgery. Amid, Liechtenstein Institute, is well known, and he published an increasingly big number of pain after hernia repair. And when you look at the results, they say there is no recurrence, but of course there is. But when you examine hernia repair with Liechtenstein mesh, with your finger, you have the mesh, you don't, the recurrence is intact. So you say there is no recurrence, but when you do surgery, you find a recurrence. Second thing, the nerves are in the mesh, and it's a part also of the pain. And I think in young people, it's not good to put a mesh who will stay for 30, 40, 50 years, and with migration and the whole thing. So for me, I don't put mesh, and I take the best one. I take Schuldeis. Mushawek, I think it's from Schuldeis she goes to the minimal repair, and it's, I think, quite the same as Schuldeis, with less tension, less pain, earlier going back on the field, but maybe in a few years there will be more recurrence, but I don't know.
I agree with Pierre.
Can I just ask, one of the problems I think we have is that when you look at the literature and you look at these case series, and no matter what surgery you will do, you'll get good results. I think the outcome, the way we measure the outcome is a real big problem. So a very nice thing to have data on, and we don't have that yet, would just be to have an objective outcome measure to see how do you do when you get this surgery. It doesn't have to be an RCT. We just want an objective outcome measure of how are they doing. That's what has been done now in the hip. And when you look at hip arthroscopy, you don't get 100%, even though they've had hip arthroscopy. So I would think it would be highly unlikely that we, with hernia surgery, would get 100% on an outcome score. And all we have to do is just to get an objective measurer to go to one of these clinics, and he'll come in, sit in a room with the patient, give the paper, and then go out. It cannot be the surgeon. It has to be somewhere from outside. And then I think we will get an idea where we're at. And then we can actually power our study as well to see where do we have to come from and where do we want to go. And I think that's probably a real big challenge in this forum.
How close are we to getting a randomized controlled trial started?
Well, it all depends. The issue that Christian mentioned is one of the issues we're working at. Another issue is the idea of what kind of surgery we should go for, and We're still not sure, and we'll have to make a further survey. But I think it's been very helpful to listen to the three of you and hear your expert opinions and your large experience. That's another thing. And then this issue about the adductor longus tendon is also something that we have to address. And finally, when I talk to Mushevek, well, she might say that it was 15% of the nerves, but when you talk to her, it sounds like it's much more nerves that are cut. And if you look at the old Extron study, that was a randomized controlled trial, the intervention, the exercise intervention that he used was what we wouldn't describe today as an up-to-date. We would probably do better results there, but still, he cut the nerve. He cut two nerves in as far as I remember, in all of the patients. And I know the reason that this study was published much later, many years after he actually did the study, was that it was heavily criticized in those days locally in Sweden. So there's still a few problems we have to solve before. So I think the next year we'll be gathering more information and probably and hopefully getting a series, as Christian describes, of how are we actually going from there. We also would like to maybe measure strength and strength development after adductor anatomy in some of these patients.
And the last question.
Yeah, I would like to know what that's what Christian talked about, is initial assessment. And I think that's a very important issue. One of the remarks was already about the lower back and SI joints, which are, in my opinion, very important. Also in prevention of the chronic groin problem. The question to me is the initial assessment. We do physical examination. What do we do in, for instance, looking for an Osteitis Pubis or synthesitis, whatever you want to use? As we've seen, we've used ultrasound. Do we use also MRI to exclude, for instance, bone marrow edema over the symptoms? Because I think that's very important also in the outcome at the end. What do we do? All three surgeries. I learned from you.
We only use MRI in difficult cases. In a standard case of sportsman's hernia, groin disruption injury, we don't use MR. It's unnecessary and it's expensive.
So you might miss out on Osteitis Pubis or bone marrow edema.
Well, we
Video
just assume that the plain X-ray will tell us enough about the state of the pubic bones to make that diagnosis.
We're talking about, I speak from experience with, not from literature. If you know what you see in football players over the ramus, superior and inferior ramus on MRIs, I think it's very important information to take in account in the initial assessment. Also taking into account the outcomes that we're talking about.
I'm there.
With all Osteitis Pubis. One of the, it's the protocol. Exclude an Osteitis Pubis.
I'm very impressed with Per Holmik's work that the Osteitis Pubis gets better. And he's got a large series, I think, of 60 patients who have had a 10-year follow-up, and the Osteitis Pubis gets better. And I don't think it's a big issue. It's part of the syndrome, but it's not going to stop the trial going ahead because it always seems to get better. It can take years, but it does get better.
Osteitis pubis is another issue that we need to make clearance for what it actually is. And I was very, very happy yesterday to hear, I think it's the first time I heard a prominent MD from Australia say that Osteitis pubis was not a diagnosis when John Reed said that yesterday, that it was more a reflection of the problem around the groin, around the pelvis. And I think I consider Osteitis pubis and I consider the bone marrow edema exactly the same as the fluid in the joint. When you have a meniscus injury, a cartilage injury, patellofemoral problems, ACL instability, whatever, you will get some fluid in the joint, but you don't treat the fluid. You treat the cause of the synovitis that causes the fluid. And in most cases, I believe that osteitis pubis is a reflection of all the stress that is put on the pubic bones, of course, because of instability that could be like John described yesterday, where there's a real instability of the joint, but in most cases, more like a muscular instability and overuse because of abdominal groin problems, hernia problems, but also adductor problems, maybe even the iliopsoas complex could make stress to that. And when you look at the Harris study from BMJ in '74, where they used X-ray, they showed that the more activity you made, the more osteitis pubis-like changes you got on the X-rays, not clearly related to symptoms. And there's been some indications of that with X-ray, with MRI as well. And we have a PhD student in Copenhagen now who just did a large series of that, and we're looking into that now, and hopefully we can publish soon. But I can allude to you that our impression is that it's the same. The more stress you put on the bone, with or without symptoms, the more bone marrow edema you get. So I think I proposed to John yesterday, some years ago, all of us, I guess, have read Karim Khan and co-workers' paper in BMJ or editorial saying tendonitis, time to abandon the tendonitis myth. And to me, it would be nice to make another editorial say time to abandon the osteitis pubis myth.
We are going to have another discussion, and we can have a discussion on with the coffee, but we have to keep time schedule, you understand? Once again, thank you very much for our speaker. This was fantastic, and thank you for contribution in discussion.